On the left side, the side we're on currently, 3 herniated discs repaired. Do I have to, what do you want me to do here? Guys, try to stay with me. We've done this a few times. Giving you some numbing medicine, all right? We're going to do 2, 3, 3, 4, 4, 5 disc repair on the left, and on the right we're just going to do 4, 5. All right, so that's good for 4, 5, not for the other levels. So Jordan, shot. That's 4, 5.
No. Okay.
Just lay still. You're fine.
Great. Keep your head nice and still.
Yeah, you're doing great. Relax. All right, Jordan. You think that's 5-1 down there? Shot. 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 All right. So we're off on orbit a little bit at 5-1, sacrum. See if you can fix that just a little bit, maybe a degree, and then on WAG. Again, he's moving. That 5-1, it's tough to see. Let's clearly see 5-1. It's clearly a different plane than the 4-5. Lay still. Don't move. You're fine. That's good. That's better. Now I see 5-1 clearly. Agree we're at 4-5, Luis? All right. Just lay still. You're fine. Shot. You're doing great, AP. So we're going to use our x-ray machine, side view and front back view, 2 views, to make sure that we're going to the right disc, and we've counted that this is the L4-5 based on the x-ray image, but also we're checking the positioning of our needle. And you can see he's got Bertolotti syndrome over there with a very large, back to a lateral please while I'm talking, a very large transverse process that articulates with the sacrum and the iliac bones. A lot of people get Bertolotti's and they wonder, does it need to be treated? I don't think so. Maybe I've seen one case that needed to be treated. You're fine. You're doing great. We found the first of 4 bad discs, or 4 bad spots, I should say. 3 discs. Making our incision. You're doing great. Just lay still. Let's do a little more local. Now, the patient has to be awake in the beginning so they can help me get to the right spot to fix. So I'm just going to give him a little more numbing medicine, make him a little more comfortable. It's okay to numb the skin. What we don't want to numb is the nerve down below. That would be bad. Shot. I may have to do a second incision for him. Shot. Because he's not going to be easy to get up to L2-3 from this incision. I can tell you that. Shot. Any questions?
No current questions.
Shot. Lay still, you're fine. So we're up against the facet. This is the L3-4 facet. You're fine. Just lay still. This is the herniation we're getting close to. Where do you feel that?
Where you feel
Shot?
4, 5 in your back.
All right. It's close. It's 3-4. All right. Almost there. Shot. AP. So you can see the tip of the 3-4 needle is in the foramen, just below the herniated disc. You can almost see the herniated disc on the x-ray there. Yep, beautiful. Let's go back to a lateral. Everybody agrees it's left 3-4, 4-5, and 2-3. Looking good. Yeah, lay still. You're doing really good. Shot.
Thanks for laying still.
Shot. Shot. You all right? You're doing fantastic, by the way. I don't think I can get that other one from here. I'll try. I might.
You need an ego anyway.
No, I know. No matter what I'm doing, but I'm just thinking out loud. The angle is a little steep. But you know what? It's worth a try. If we can keep it to one incision. I think we did all three. It's not bad. It's not bad. Let's see. Up against the facet, shot. Or TP. Shot. Just a little too medial, which is fine. Shot. Shot. All right, you're doing good. Shot. Almost done. Shot. AP. Now the curvature of his spine is pretty good, and it's allowing me to probably access that 2-3 disc. So pretty far lateral there though. Back to a lateral view. We're going to have to get a lot closer to the disc. Yeah, we're too far lateral. Let's try that again. Shot. Shot. Lay still. Shot. Don't move around. Almost done. Shot. Shot. How's our blood pressure? AP. Huh? That's much better. So for those of you wondering why are we doing this surgery, this patient has 3 herniated discs, L2-3, 3-4, 4-5, and they're really on the left side primarily, but 4-5 has a right-sided herniation as well. So we're going to fix both sides at L4-5. Shot? Okay, sound good? Now we're done with this side. We're going to get started on the other side. On the other side, we're only doing one L4-5. Shot? 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 Let's go AP. We need to use 2 views, AP and lateral. Some surgeons will use an oblique view. I used to use the oblique view years ago, but I got away from it because this is far more reliable to go with the lateral and the AP. Shot? Shot? Perfect. Shot? Shot? Can actually feel the herniation. All right. Not bad. Not bad at all. So I was saying, why are we doing the surgery? Is he awake? And is blood pressure good? We're doing the surgery because he's having back pain in this area of his back. Sound familiar? Many people do. And there's really only a few things here that will cause back pain. And those things include the discs, if they have a tear, which he has 3 discs with tears, called annular tears. You can have a fracture here, which he doesn't have. You could also have a tumor or an infection, which he doesn't have. You can see those on MRIs. And you can have facet joint pain. The facet joints are out here. If he had facet joint pain, his pain would be in a different pattern, a different location. And he doesn't have facet joint pain, he has disc pain. All right, so we're gonna verify that. Are you comfy? Huh? Like awake? Comfy?
Yeah, Aaron, try to keep your head down, Aaron. Aaron, keep your head down.
We're gonna put you to sleep soon, okay?
Keep your head down.
Let's not use names.
Keep your head down.
All right. Is he comfortable? You want to go get that phone and see? That's my phone. Yeah, that's all right.
Hey, buddy, keep your head down. You're doing great, okay? You're doing great.
Let me know when he's ready. He's ready.
I'm sorry, I just missed it, but I can't.
No problem. Are you comfortable?
My friend. You okay? Yes, he said yes.
All right.
Try not to move your hands, though, okay?
Just keep your hands still.
Your hands still. Okay. We're going to just put the strap on to remind you.
All right. Well, let's get a nurse up there to help you. Watch your sterile field, Luis.
Okay, my friend. Open your eyes. Good. Okay, head down. Okay, good.
Are you comfortable? All right. Let me know. I just want to make sure you're awake and comfy. This is L2-3. This is L3-4. And this is L4-5 disc. These are discs. You okay? All right. How bad is that on a scale of 1 to 10? Is that where you typically get pain? All right. So we found the first of your painful discs. You want to know which one that was? No. No, that was 2-3. So it was close. Is it better? Yeah. All righty. You feeling all right? Yeah. How bad is that on a scale of 1 to 10? 8.5. All right, we round up to 9. So that was a 9 over 10. Is that where you typically get pain? Yes. We call it concordant if it's typically where they get their pain, which it is. All righty. You better? Comfy? Yeah. Okay. Now that's 4/5. How bad is that? What's the number? 10. Okay, all right. You can go to sleep now. When you wake up, that pain will be gone. Okay. Congratulations, we found your 3 painful discs. All right. So some of you may be asking, why are we doing 4 or 5 on both sides? The answer is just count out loud from 1 to 100. The reason we're doing 4 or 5 on both sides is because the patient has leg pain on both sides, and it's coming from the L4-5. Shot? Shot? All right. So we're going to start with L4-5, removing the spinal needle, which is used to navigate. And we got our guide wire, which is what's taking over the navigational job. We're going to use a dilator. It's like a long, skinny metal pencil that's going to spread the tissues without damaging them. It's going to go all the way down past the fascia through the paraspinous muscle, shot. And it's going to go right into that herniation and push it back into the disc. Are you okay? Now, the case highlights some good job, Jordan, some interesting points, which are not everybody responds to the anesthesia the same way. Some patients have more tolerance than others. And, you know, we have to balance that tolerance with safety. We cannot jeopardize the patient's life, so we cannot put them so deep that they stop breathing. This is not a general anesthesia case. This is a MAC case, and it means sedation. So our patient doesn't have a tube down his throat. So the anesthesiologist has a very difficult job of controlling their level of awareness of the patient without making them too deep that they stop breathing. Just lay still, you're fine. Shot, that's it right there? All right. So our dilator comes out, you see that? And what we're left with, can you see this, Henry?
Yes.
A small tube. Now, I'm going to remove the herniation through this tube, and I'm going to repair the tear in the back of the disc where the herniation came out of. And when I say repair, what I mean is I'm debriding it. I'm not really repairing it, closing it. I'm debriding it so that it can repair itself. There is no way to really repair the tear. The body has to repair it itself. But we as surgeons, just like we don't do a fusion, when we say we're doing fusion, we're not fusing, we're putting bone graft there to allow fusion to happen. Guys, I need to see what my scope here. Yep, thank you. Good?
And then lights off, please.
All right, so we're going to just work on the focus. There we go. And you can see we're inside the herniated disc, right inside the herniation itself and the tear. And I'm going to use a laser to clean this out. The blue is the dye that I put in there to help me identify the herniated disc. I'm going to bring the laser fiber. You're going to see it in just a moment. There it is. Now this laser fiber is a little different than the one we use for cervical. This laser fiber is a 1 millimeter fiber. There's a piece of herniation right there. So why don't you, for our audience, Henry, would you run a video showing why do herniated discs cause back pain? Why are they the most common cause of chronic back pain? How does that work?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, let's show the audience with another video what we're doing here with the Deuk laser disc repair so they get an idea of how this works. Your questions up, folks.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Really have a uniform definition of time in, right? It gets confusing, but there's no confusion about wheels in. Wheels in is when the gurney with the patient goes in. It doesn't matter when the anesthesiologist comes. It doesn't matter when Luis comes or you. What matters is when the gurney with the patient rolls in the room. That's why it's called wheels in. So all the other names and acronyms are meaningless except for wheels in and wheels out. So what that's referring to is when the gurney with the patient is actually wheeling in the room for the first time and when they're wheeling out of the room after they've been recovered. Okay? So those are the time points. I want wheels in, and then I want to know when you guys are ready for incision. That's when you're ready for the surgeon, me. Okay? And then I want to know when I walk out, like when I'm done, we're finished. And then I want to know when the wheels go out. That means, just lay still. That means when the patient is recovered to the point the anesthesiologist is ready to take him out of the room. How are we doing there? Want me to wait? How's the IV flowing? Good? All right. Yeah. All right. Any questions from our audience?
No current questions.
All right. Why don't you go ahead and type in the free MRI review address in case somebody wants to get a free MRI review done. We do free reviews of spine MRIs, whether it's lumbar, cervical, or thoracic. Those are the three parts of the spine. And if you know somebody who's suffering with back or neck pain, get on to our website and send in the MRI. We'll be happy to look at it. Now, I get people contacting me on Facebook all the time, and they send me their MRI on Facebook, on direct messenger. I don't review those MRIs that way. That's not diagnostic. I need the entire set of images for me to be able to make the right diagnosis. I can't diagnose a person's problem with one picture or two. So if you're out there on Facebook and you want to send me a DM with the images, don't do it. Just use the link that we're posting now. And if you use this link, you could upload your history. Where is your pain? How long have you had it? Does it go down your leg? Which leg? And we'll set up a teleconference where I'll be able to interview you over the over Zoom, and I can actually see where your pain is and make sure we're making the right diagnosis, because you can't make surgical plans or treatment plans without the right diagnosis. That's what's gotten us into the problem of treating people's back pain and neck pain wrong, ineffectively. That doesn't work because too many people treat based on just the MRI. You have to treat based on the physical exam. And that physical exam is going to be supported by the MRI. But you don't just use the MRI to base treatment decisions, okay? It's one of the biggest things I encounter on the internet is people wanting for me to give my opinion on their treatment just based on the MRI. And it's not possible. We need more information than just the MRI. All right, remember, this is L4-5. There's a lot of inflammation going on here. You can see it. A lot of vascularity and inflammation. And it's a pretty bad tear. But it's coming along quite nice. This is all lateral herniation right here. It's kind of a paracentral right outside the foramen. This can definitely hit on the nerve root, so that's why we clean it up. It's looking good. You can see his end plate over there, the pink thing. And see what that is. Just about done. Little bone spur calcification right there. Not bad. Looking good. It's got a little, almost looks like some fat necrosis there. Some of the fat in the epidural space. But so far, it's going very well. This is again his L4-5 on his left side. We'll do the L4-5 as well on the right, and that will probably be the last thing we do is the right L4-5. So we're going to start with the left L4-5, and then we're going to work our way up to 3-4, and next, and then 2-3. All right, I really hope he gets good relief. Clearly these discs are causing his typical pain that he gets every day. You saw his response. He was coming off the bed when I was doing the discogram. So I was confirming that these discs are indeed the source of his pain. And he had an 8 out of 10, 8 out of 10, and a 9 out of 10. Whoa, was it 8 out of 10, 9 out of 10, 10 out of 10?
8, 9, 10.
Yeah, it was 8, 9, 10. You're right. I think it was. Because he did an 8.5, which we rounded up to a 9. Yeah, but clearly we asked him, is that where you typically get your pain? And he said yes. So the good news is I was right based on my diagnosis that it's disc pain. And actually he himself knows that. He actually told me. He said, I think it's my L4-5 and L3-4. And when I first talked to him, it was just those two discs. But then it's gotten worse, and it's involving L2-3 as well. When I examined him in person, when I saw him yesterday and examined him, indeed, L2-3 was also a problem. He was having pain up that high. So he wanted to add on the L2-3 yesterday, and I said, sure, we can do that, no problem. I don't want you coming back. And he was happy about doing that, so we're doing the L2-3, 3, 4, 4, 5. And I just tested L2-3, and sure enough, it is definitely causing his pain as well. This looks good. I think we're pretty much done with this side. Sometimes we can actually see the needle on the other side, coming in from the other side, when we look. Let's see. No, I don't readily see it. So, all right, we're just about done here. Do a little bit more right there. And pretty much finished. Yeah. We're going to clean this out with some betadine. And let's hope this thing heals nicely for him. Any questions from our audience?
No current questions.
All right. Somebody asked me in the last surgery I did. By the way, the first surgery, the lady's gone home. That was the 3-level cervical. If you guys watched this morning, we did C4, 5, 5, 6, 6, 7, 3 disc herniations. Her pain is 100% gone, and she now has normal strength in her arms. When I examined her in clinic, she had weakness in her arms. She had weakness in both arms, and now she has completely normal strength in both arms. So already immediate regain of strength and feeling. She said the numbness in her thumb is gone. She's so happy, but she's already left with her husband, and they'll be coming back tomorrow. Maybe we'll get lucky and be able to do a testimonial. All right, we're done with this L4-5 on the left.
Lights on, please. Thank you. 12 off. One second. One second.
Huh?
Okay, good.
Oh, I'm sorry, I pressed the wrong button.
We're good.
Thank you.
We're good. Take. It's nice to hear him snoring peacefully. Okay. Now, most patients with this problem of 3 herniated discs are going to end up getting recommended for a fusion by their surgeon. This patient did not want a fusion. He was 100% opposed to it. He's young and very active and wants an active lifestyle. And, you know, he didn't want metal in his back. He's actually a healthcare professional. He's a doctor, and he knows what fusion means. I can tell you that. And he didn't want fusion. So he came to Deuk Spine Institute for the Deuk laser disc repair. That's what he's getting. And so far, it's going really well. He's very comfortable. He's sleeping. And we're going to move from the L4-5 next over to the L3-4. I got it. All right, team, good job so far. Any questions from the audience, Henry?
No current questions yet, Doc.
Alrighty. Now, for those of you watching, if you're interested, we have an app, a Deuk Spine Institute app, and it's free. It's on the Android as well as the iPhone or iOS system. And you just need to go to the App Store and you can download that app. Shot? So we're going for the L3-4 next. It's hard to see, but the L5-S1 is down there at the bottom. And you can see the needle in the L4-5. That's coming from the right side. We have yet to do the right side at L4-5. Now this L3-4 has a good sized disc herniation that we're about to get into. So, shot. All right. This will be a little stimulating. Shot. Oh, amazing. Huge, huge tears in the back of the disc. Just huge. It just goes in so easily, you know? Lay still.
Okay, buddy. You're doing great.
You're fine.
Great. Let me hold your hand. I got your hand, buddy.
Yeah, you're doing fine. Lay still. Let's get a shot. See where we are. Perfect. All right, remember I was telling you all earlier, don't get bothered, but this is typical for MAC anesthesia. Your patient is never completely out, so there is going to be these periods where they're more responsive and periods where they're less responsive. It's all just part of the surgery and the anesthesia. You okay? All right, looking good. We're going to move the fluoro machine out again so we can do the surgery. We've got our tube in. You can see the tube. This is endoscopic spine surgery, by the way, for those of you who are joining us late. And the specific type of endoscopic spine surgery is called the Deuk laser disc repair. It's originated here at Deuk Spine Institute in Florida. It's a transforaminal technique, which is becoming more popular. When I started doing this 16 years ago, almost nobody in the world did it. There were a few surgeons. It was developed originally by Dr. Parvis Cambin in Pittsburgh. He was an orthopedic spine surgeon and really a genius. And he thought, hey, why go and take the bones and ligaments out of the spine to do back surgery when you can just go through the hole that's already there? That way you don't damage the spine that's normal, the normal parts of the spine. You don't have to get all this bleeding and scar tissue. So he developed this technique, and he had a lot of complications. You know, when you're a pioneer at something, sometimes you get a lot of complications. So his technique wasn't very popular. Not really very many people accepted it. And it was around the same time that fusion was starting to get popular, which, you know, fusions have had a lot of complications too over the years. But there's a difference, you know, with fusions, there's companies that are making billions of dollars in profits with fusion by selling screws and rods and cages. And those companies drive the business. They go and they basically pay off surgeons to put in metal. And that really pushes the whole metal industry in spine, like drives sales of fusions. But fusions are bad for people, and it's totally unnecessary. The thing about this type of surgery is there's no implants right now for this kind of surgery. There's no metal. So those companies that market spine treatments, they don't get money from this surgery, so they don't promote it. And it's unfortunately, because of that, it struggles to gain traction, because surgeons that do fusions, they make a lot more money than these types of surgeries, so they're motivated by money to do more invasive procedures. Now, that said, there are still surgeons like myself that believe you should always do what's best for the patient. And when you adhere to that philosophy, you're gonna do less invasive surgery that has a better outcome than fusion. And that's what you're watching right now. This doctor that we're treating right now is actually an interventional doctor, interventional pain management doctor. He's incredibly gifted and smart, and he is compassionate and wants to help people in pain. So he knows about fusion. He knows how damaging screws and rods and cages are, and he didn't want it. He wants something that works, that's less invasive. That's what he's getting.
We have a couple questions.
Sure, we'll take the questions.
The first one comes from YouTube, and the name Khaled. And they asked, excuse me if I say anything wrong here, if you have spinal stenosis due to ligament flavum hypertrophy and disc bulge, do you treat it for a transforaminal approach?
Yes, so great question. The question was, if the patient has spinal stenosis with ligamentum flavum hypertrophy and bulging disc causing the stenosis, can you use this surgery you're watching now, the Deuk laser disc repair, transforaminal? Can you use this to fix the problem? The answer is 100% yes. There is no spine condition that's degenerative that we can't use this treatment to treat. Spinal stenosis, yes. Herniated disc, yes. Bulging disc, ruptured disc, protruding disc, yes. Degenerative disc disease, yes. Pinched nerves, yes. The only things we don't treat with this surgery is spinal fractures that are unstable, and tumors and infections. So if you have a tumor, infection, or a fracture, we're not going to do this surgery. And then, of course, if you have really advanced degenerative condition with really, really, really unstable spine where things are sliding everywhere, all your bones, then this won't work either. But this works for 95% of patients with spinal stenosis. It works for 95% of patients with herniated and degenerated discs. There's only a small number of people it won't work for. And the way you find out if it's going to work for you is just send us your MRI. We'll look at it. We'll do a video chat where I can examine the person, see where their pain is, see which leg it goes down, and do a quick exam. And once I do that examination, there's a piece of herniation there. Once I do the examination, I know exactly what needs to be done. Now, sometimes I'll have to order a nerve test as well if the patient doesn't have it, maybe even a CAT scan. But generally speaking, I can make the diagnosis accurately about 98% of the time through a Zoom telemed along with an MRI review. So as long as I have the patient and I have their MRI, or preferably MRI, then I can figure out what's wrong. Now, people ask me, Dr. Deuk, when you go in there and take out the disc, what's going to be there? And the answer is, we're not taking normal disc out. All of this is the herniation. That's all we're taking out is the herniation. The herniation isn't normal. And you don't want the herniation in your disc. That's the whole thing that's causing all the problems. So there is no like normal disc that we need to put back because we're not taking normal disc out. We're only debriding the annular tear and removing the herniated fragments. And as you saw from the last surgery and this one, there's usually many fragments of herniation. People think a herniated disc is one event. Oh, I herniated. No, it's usually like 30 pieces that have to come out. Highly vascular here. Inflammatory. Great question. Henry, do we have any more questions from our audience?
Yes, we have a question from Shane on YouTube,
Hi, Shane.
and they asked, is he awake?
Is the patient awake? That's the question. The answer is yes. He's awake and he's not awake. He's sort of in twilight, what we call the twilight zone. And the anesthesiologist wants him to be asleep, but not so asleep that he stops breathing. That's really the thing we have to watch out for. We want the patient comfortable, but not so sleepy that he stops breathing. You know, you've heard stories about people being so much alcohol they drink that they stop breathing, right? Or they take heroin or fentanyl, they do drugs and they stop breathing. That's because these drugs all affect the respiratory center in the brain. The respiratory center is the part of the brain that drives breathing. And the great thing is that it does it without you even thinking about it. Sure, you can sit there and go, take a deep breath, and you'll take a deep breath, right? Because you're forcing yourself to. But imagine when you're sleeping at night, having your dreams, you're not thinking about breathing. You're not making yourself take breath. So what's happening is there's a part of your brain, it's in the brainstem, and we know exactly where it is, and that part of your brain automatically makes you breathe. Now, that part of your brain will work and work and work and do a great job for you until you shut it down with too much of certain drugs. All right? And so the drugs we use are drugs that put people to sleep, but they're the same drugs that shut down the breathing center. So at really high doses, it shuts down breathing, but at lower doses, it puts you to sleep. So we have to just balance it just right to where the patient has enough drug to make him sleep, but not enough drug to make him stop breathing. So it's called conscious sedation, I think, right? Would you call that conscious sedation?
This I would call deep sedation.
Deep sedation. All right, deep
Conscious
sedation.
is when you're testing the disc.
When you're what?
Testing the disc.
Yeah, conscious sedation is a little bit lighter. My anesthesiologist has informed me. It's when you're actually awake and you just don't care what we're doing to you.
But you do respond to
But you do respond. Yeah. Right now he's deep enough that he's not going to respond, and he's comfortable. So I hope that answers your question for you. There is no tube down his throat, not like the first surgery we did earlier today.
That's called general endotracheal.
Yeah. Yeah, the earlier surgery is called general endotracheal anesthesia. That's when they're completely zonked out. But we don't do that for lumbars. All right, so far everything's going quite well for him. I'm removing herniated material and checking everything out while I'm in here. It looks good. Now once I clean this tear up and get rid of the herniation, this should heal up on its own. And by the way, herniations generally do try to heal up on their own. You can see there's some scar tissue here. And This part here was pushing on the nerve right here. So that's all herniation right there. I'm going to get rid of it. By the way, I always tell people how many of these cases I've done. I've done 1,500 patients plus. In other words, more than 1,500. And I do an average of about 2 discs on every patient because most people have more than one painful disc. And so when you add it all up, I've really done around 3,000, really 4,000 discs, you know, with the laser. Endoscopic, 4,000 in 1,500 plus patients. Because we do an average of 2.4 discs per patient. And that's one of the things I think it's important to understand. When you go see your doctor about your disc problem, most doctors only want to fix one disc at a time. So they're going to tell you, let's fix the worst one. Well, guess what? You're going to get done with surgery and you're still going to have pain. And then you're going to get what's called adjacent segment disease, where you're going to end up having to come back and have another surgery. All right. How's our irrigation? Almost done. Lay still. No, don't move. All right, so there he's a little bit lighter than we want him to be, but still he's okay. And our anesthesiologist will put him down, make him a little sleepier, but it looks good to me. That looks good. You can see the nerve up there at the top at 12 o'clock. And again, I want to make sure we get, yeah, almost done. Standby laser. Yep. Looks good.
Good?
Yeah.
Lights on, please.
All right, we're done with 3-4. Little betadine to clean it out. We call it antiseptic. Then some irrigation. Just lay still, you're doing great. So you can see we've lost very little blood, almost nothing. And lay still. You're fine. We're just cleaning it out. You're doing great. Yeah, he's fine. He's not happy with me right now. But look, we've got a great relationship, a great understanding. Right? Just lay still. You're doing great. You're doing great. All right. 2 discs have been repaired with the Deuk laser disc repair. On the left side, that's L4-5, L3-4. Now we're going to do L2-3. So we're going to get our machine, our fluoro machine, back in. Want to make sure it hasn't moved. All right, go back to the north a little bit. Looks good. Go ahead, Luis. Hold this. All right, so we're actually able to do all 3 discs with 1 incision on the left. This incision, folks, is 7 millimeters. Shot. So it's really tiny. Is he okay, Doc? A what? You need me to stop? All right, so folks, I want you to look here. This is our dilator. This literally slides down the guide wire. It spreads the tissues open, doesn't hurt anything inside. The only thing we're hurting is we're cutting the skin here with a little 7 millimeter cut. And now I'm going to push things over as I go in. When I get done, I'm taking this out, and all the tissues will collapse back without any damage. This is minimally invasive spine surgery at its finest. Shot. Shot. people talk about doing minimally invasive spine surgery, but there's only a few surgeons that actually really do it. Shot. Lay still. Let me have it. Shot. Uh-huh. Give me a little wacky wacky. I'll tell you when. Hold on. Are we ready, doctor? Wait a minute. All right. So what I'm saying is, hold pressure. Hold pressure. What I'm saying is, the term minimally invasive spine surgery is getting thrown around a lot. There are surgeons that will do a cut on your back that big and call it minimally invasive. There are surgeons that will do it this big and call it minimally invasive. The reality is that this is the least invasive true spine surgery that actually works. So this is minimally invasive spine surgery at its finest.
Okay.
Mallet. Shot. All right, so we're entering, you can see 5-1, 4-5, 3-4. This is 2-3. Shot. Just relax, you're doing great. Yeah, you're fine. Everything's good. Hold on. Now. Shot. Yep. So this is the L2-3. This is the top disc. There was a herniation we saw on his newest MRI. So he brought an MRI just 2 weeks old, and actually maybe even a week and a half old. And that showed that his herniations were worse. That's why we always ask people to make sure we have updated MRIs. Shot. That way we can actually, you're doing great, almost done. That way we can actually make sure we're treating everything that needs to be treated. I know it appears brutal, we're hammering this thing in, but that's the safest, easiest way to get it in. So far, everything's going well for this patient. Right, doctor? And once we're finished here with this disc, we're going to move over to the L4-5 on the other side.
Endo, on the seating, please. And stand by the lights, please, for the scope. Thank you.
Scope on. Lay still, you're doing good. All right. Once again, a lot of inflammatory tissue. Okay. Herniation as well. Now this is, on the MRI, this herniation, in my opinion, is the smallest of the three. You know, L3, 4, 4, 5, 5, 1. But I can tell you right now, doctors get fooled by the size all the time. They look at something and they say, oh, that's too small. It couldn't possibly be causing symptoms. But small herniations can be very painful. You can have a tiny herniation called a grade 3 out of 5. And even a grade 3 could be severely painful to the point you can't even walk. You want to know what's funny? Is there's so many people who don't understand that herniated discs are painful. There's so many doctors who think discs can't be painful. And yet, what taught me that discs can be painful, besides obviously operating on them and taking away people's pain, practical experience, but there's a condition that neurosurgeons know about called discitis. And discitis means inflammation of the disc. And a lot of times when you have a patient with discitis, they don't have an infectious cause of the discitis. There's just no infection seen at all. And it boggles most neurosurgeons. It boggled me, like, why does this happen? And I started thinking about discitis and thinking inflammation of the disc can be so painful. Like, it's the most painful condition of the spine, is discitis. Everyone accepts that and knows it. Except, for some reason, neurosurgeons don't accept that you could have localized discitis in the back of the disc where the tear is, which of course you can. That's how I figured out the tear was the cause of the discitis. And that's why we treat the tear with the Deuk laser disc repair. The problem is that other doctors are so far behind in this knowledge and understanding that if you go elsewhere, you're not going to find the answers you need to get better. So that's why we try to spread the word to the population. Patients, doctors, nurses, everyone. And the word is getting out there. And it's making a difference in people's lives. You're good. We're almost done here. Did you change the irrigation? Yeah, you got to tell me when you're doing that. All right. Well, you don't, I know you need to tell me, okay?
We have a couple questions.
Sure, be happy to answer.
Awesome. This first one comes from Brian Johnson on YouTube.
Sure.
And he asked, how far do you extend the tube into the disc?
How far do I extend the tube into the disc? That's the question. Great question, Brian. I go in just far enough. But in all seriousness, you want to go through the tear all the way from outside to in, and you want to try to push the herniation back into the disc so that you can deliver it from inside the disc. That way you're not messing around by the nerve roots. Because if I have to mess around by the nerve roots, then I put the nerve roots at risk of injury. So my goal with putting the tube in is to go in far enough I get through the tear all the way to the bottom where the tear starts. And then I start cleaning that tear, debriding it from the inside out as I work my way out. And that's what I do. So we don't go in too far. We go in just enough to get through the tear to the bottom of the tear and find the herniations that I just shoved back into the disc and remove them. And then you can see me twisting and pulling. What I'm doing is I'm actually pulling the tube backwards towards me, towards the outside, so that the end of the tube moves towards the outside of the tear. And when I get all the way through the tear, I'm done. Great question.
This next question comes from Macho Hunter on YouTube.
All right, Macho Hunter.
And they asked, can a damaged nerve regenerate?
I can't hear you. I'm so sorry.
No, you're good. Can a damaged nerve regenerate?
Can a damaged nerve regenerate? The answer is yes, but it depends on the kind of damage that the nerve has encountered. It depends on where along the nerve it gets damaged. Is it near the cell body, or is it further away from the cell body where the repair process, like the factory of repair process is? And then of course, is the nerve in the central nervous system, or is it in the peripheral nervous system? So a nerve in the brain cannot repair itself, but a nerve out here in the peripheral nervous system can, because there are different support cells, different capabilities of repair. So a spinal nerve, like the ones that we're decompressing and treating here, these can generally repair themselves, yes, quite easily, as long as they're not transected. Transection means cut in half.
All right, and our next question comes from Kevin Bishop on YouTube.
Hello, Kevin. Welcome to our broadcast at Deuk Spine.
And he asks, why does the herniation have a light blue appearance?
Why does the herniation have a light blue appearance? That is the dye that I injected during the discogram. And what the dye stains, it stains herniated disc. It will not stain bone, and it will not stain the annulus. It will not stain scar tissue. It only stains herniated disc and like elastic fibers. So you can see some of those fibers right up there. That's not part of the herniation. We're not going to mess with that. Those are just some fibers. This is the annulus right here. It's torn. But mostly what it stains that I'm looking for is the degenerative nucleus. That's what it stains. That's right here.
And you
This stuff.
score him to the up there?
All right, we are pretty much done. There's an epidural vein right there. So we are done with this disc at L2-3. It looks good. Yep. Maybe a little calcium deposit right there. Yep. Blast it. Get rid of it. Don't want it. Done. Let me see. Let me just check this one area.
Maybe this can support him. Oh, he's going to the lobby. He's sleeping. Yeah.
By the way, you have to know your anatomy pretty well if you want to do this kind of surgery. You got to know what you're operating on and what you shouldn't be operating on. Accidentally. Almost done. Just about there, my friend. Hang in there. We got one more disc to do, and we're going to get you out of here. So this poor patient's life has just been ruined with his back pain. And he's put off and put off and put off getting this thing done, which, you know, we always hope that conservative treatment will work for people, you know, but it doesn't work for everybody.
Lights on, please.
And lay still, you're doing great.
Yep. Scope off, please. Thank you.
Don't move, you're doing great. Little betadine in there, that's antiseptic.
Oh, thank you very much for your time, buddy. Send me an email, please. Thank you.
Stay still. Lay down, bud. Lay down.
Let's go.
Head down. You're okay.
You're doing great, we're almost done here. Stop bothering you in a minute.
You're okay, bud.
You can't be poking needles at your boss, all right? Not me, I'm talking about Luis. Here. He won't like you if you stick him. Yeah, you did it. All right, so just kind of moving some of these cables around. I'm going to show you guys what we did. Basically, we fixed 3 discs with one tiny little hole. And before you come in, Jordan, let's take a look over here. If I had to do a fusion on this patient, my cut on his back, can you guys see this?
Yep.
Would literally be that big from there to there. That big. You guys see this? It's about 9 inches.
Yeah, we see it.
Okay? For some guys who know, you know. If you don't, you don't. I'm sorry, but some people know what 9 inches are and some people don't. But I'm just saying, that's what 9 inches looks like. I'm sure my patient's going to appreciate the humor when he wakes up and watches his surgery. All right, so you'll get a better view of what I'm talking about. You guys see this right here?
Yeah, we can see it.
So it starts here, one cut, all the way to there, right where the top of the butt crack is. I've done 1,000 of these surgeries with screws and rods, and that's what he would have had done if we weren't doing this procedure. He'd have no other option. Yeah, I'm going to switch sides. So let's just check. Can you guys see this? We did all 3 discs. Look at this. You see that?
Yep.
7 millimeters. Go ahead and put pressure. So we're going to put a little pressure on the muscle just to make sure there's no bleeding. And what you don't want if you're doing these transforaminal lumbar surgeries, you don't want a blood clot under the skin. So it's very important, your anesthesiologist. Everything okay? You can let him wake up a little bit. It's very important we get the blood pressure under control for the surgery and not get a hematoma. How's he doing? All right, let's just take our time. I'm not going to, you want me to stimulate him or just wait? Yeah, just lay still. Would you help with the arms, please, Jordan? Obviously. The guy's trying to do push-ups. This is not the time for push-ups. Yes. Yeah, go ahead. Yep, no problem. Just lay still. We're almost done. One more to go. You're doing great. All right, any questions from the audience?
Yes, multiple.
Doc, let me know when I can proceed, okay? Do we have any more of the local? I'm going to put a little more local. And we put the local into the discogram thing, right?
Yes. Yeah,
Lay still.
doing great.
We're trying to finish your surgery, okay? So we're waking him up a little bit because we don't need him so deep right now. Just make sure he's still breathing and doing good. What's the question?
Yes, the next question comes from Khaled, again from YouTube. And
All right, I'm having trouble hearing you. It seems like during the surgery you move a little bit away.
yeah, I do. I place it at a wrong angle, but this sounds better. So yeah, the next question comes from Khaled on YouTube again, and they ask, "What's the name of the laser machine that you use?"
The name of the laser machine. Great question. Should we tell him?
I say sure.
It's a luminous laser. It's a holmium YAG. Lay still. Everything's okay. You're doing great. Surgery's almost done. How are we doing over there, Doc? So the name is the luminous, and it's a 100-watt laser. We usually use it at around 30 watts for the lower back, and 20 watts, 30 joules for the lower back, and 20 joules for the neck, for the cervical. Let me know when I can proceed. All right, so we've gotten the green light. We're going to move forward, and this is the L4-5 on the right side. Right side. We're getting his BP under control. All right. So now the interesting thing is some patients with chronic pain, they just have a lot of anxiety from that pain. It really messes with their emotional status, and it's horrible. People living in chronic pain, it just really affects every part of their life and even causes horrible anxiety in some people. So that anxiety really affects their response to pain.
We have another question from Facebook.
Yeah.
It comes from Elaine Keever, and
What did you do there?
they asked, "Will Medicare pay for the surgery if you are from out of state of Florida?" And also, I have Aetna supplement insurance.
Great question. So this particular surgery is not going to be paid for by Medicare. Not yet. Someday we're going to be going to Medicare and basically having to fight them probably to get them to cover it. But right now Medicare doesn't cover new technologies like this. And lay still. And we're not prepared to take them on just yet. We're actually working on the Blue Crosses and the Cignas and the Uniteds at this point and having some success. But that's going to be our first challenge, is getting consistent coverage from some of the major insurance companies where they cover it all the time. But that's always an ongoing challenge, is reimbursement. Insurance companies don't cover what's best for patients. A lot of times they cover what's worst for you, because they know that if you know you're only getting the worst treatment, you're not going to take it. Therefore, you'll just live in pain, and then they save the money. And it goes to their bottom line at the end of the year when they report their profits. That's why insurance companies' profit margins are so high, is because they're denying so many treatments now, especially the good treatments. All right, guys, we need a little more pressure on the irrigation. I need that screen moved out towards where I could see it. Okay, somebody turn the light on and then we turn it off. There we go. Yep. Hey. Hold on, Jordan will help you. Show her how to do it. All right, very good. Yeah, you got to undock it, right? Yes, thanks. So, insurance companies love it that fusion is what they cover because they know most people won't get it done, which means they're not going to have to fight you. Think about it. If I have a meal plan and I want to make money, I could sell tickets to the meal plan to $20 a person. That's your premium you pay for insurance, right? But if I don't want you to eat the food, then I just have really bad food on the menu. And then I get to keep all my money that you paid me. That's what insurance companies do. They basically only give you the choice of the worst things, and some people are desperate enough to eat that food. But, you know, what people should be doing is demanding better quality, and that's not happening. So one thing we do at Deuk Spine is we try to raise awareness about this issue, that Medicare is not covering the best treatments available, so that people can advocate for themselves. You know, as a surgeon, it's not my job to fight your insurance company for them to cover what you need. Get these cables right. It's your job to deal with your insurance company and get them to pay for your medical care. So a lot of people just get upset when they find out their insurance won't cover newer treatments. But they need to get upset with themselves for not advocating enough. And really what it comes down to is it's truly at the level of the state, except for Medicare, and then it's at the level of the federal government for Medicare. And what's happened with Medicare is really just a bank account in the federal government now. And as far as the benefit management of Medicare, you got to watch that loop, you know. It's too close there. You got to pay attention. The management of Medicare benefits occurs with what's called Medicare administrators, or MACs. Look it up. And the MACs for Florida is a Blue Cross subsidiary called First Coast Services. So if you have straight Medicare in Florida or Puerto Rico or Virgin Island, it's going to be managed, your benefits are managed through First Coast Services, the Medicare administrator. Well, that's owned by Blue Cross Blue Shield. So what's happened is the federal government has basically sold out to the private insurance companies who are experts at denying paying for things, called a denial. And these companies promise the government, if you let us manage your benefits, we'll save you money. And the government said, okay, well, we're going bankrupt with Medicare, so if you can save us some money, that's great. And then the government says, well, how are you going to save money for these Medicare claims? And Blue Cross says, don't ask. Don't ask. Just let us work our magic. Well, there is no magic, folks. The magic is denial. They just deny treatment. They deny your MRI. They deny your prostate surgery. They deny your breast biopsy. They deny your mammogram. Whatever. They deny, deny, deny. They say it's not medically necessary, and they make up some cockamamie reason not to cover it. Okay? That's true. That's what's happening. And it needs to stop. You know, Medicare patients used to get unlimited physical therapy when I started practicing back in the 90s. If you were a Medicare patient and you needed hip surgery, you'd get it, and then you can have as much PT as you needed to get better. Now, those benefits have been cut over the years by guess who? First Coast Services, your Medicare administrator, to where now Medicare beneficiaries only get like 25 days. It's maybe less than that today. Every year they keep cutting. The point is, the government has made a deal with the private insurance companies to basically save money for the government by denying your treatment. Now, the government doesn't want to deny your treatment because then you get angry at the government. But when the private insurance companies do it, they just call it not medically necessary, so it looks good on paper. That's what they do. We're fighting those kind of cases, and we plan to win because it is medically necessary. We're just not ready to take on Medicare yet, but we will someday, trust me. It's my mission in life to fight for you guys to get the best medical care you can get. Then there's actually more people like me out there, believe it or not. There's a group of us, and we absolutely hate what's being done to people because you guys are being lied to. Everyone thinks they're getting great insurance. Oh, I have Blue Cross Blue Shield, it's so good, it's the best. And then when it comes to paying for better treatments like this, they try not to cover it. They try to deny it. So the reality is they're not the best. They're the best as long as you don't need insurance. Then, the moment you have a claim, they're not such the best. It's just like State Farm. They're a good neighbor. Like a good neighbor, they're there for you, except when you actually file a claim and you're injured and you need medical treatment, then they try to deny it and say it was pre-existing. All right? I do this. This is my business, what I do. I see these claims, I see these issues. I know they are real, they exist. But we're trying to help people fix them. All right. Next question.
Next question comes from Brian Johnson again on YouTube.
Hi, Brian.
And
You
he,
got to put your mouth next to that microphone because you keep drifting away and it keeps cutting out.
apologies for that. Yes, next question from Brian
2
Johnson.
minutes.
Can scar tissue alone cause pain?
Can scar tissue alone cause pain? Absolutely not, Brian. Great question. What happens is people get scar tissue from spine surgery and it tethers their nerve, holds it down. Nerves have to be free to move. Okay, they should never be tethered down and suffocated. So if the nerve is held down by scar tissue, then what happens is your bones are moving, your vertebrae are moving at the disc, and that one vertebrae goes left and the other vertebrae goes right, and the nerve is stuck to both of them. Then the one that goes left pulls half the nerve left, the one that goes right pulls half the nerve right, and the nerve gets squeezed hard, and it doesn't like it, so then you get pain down your leg or arm. So scar tissue itself doesn't cause pain, but movement at a joint where the nerve is scarred down to, that does cause pain. Hope that helps.
And next question comes from Gail Clark on Facebook.
Hi, Gail.
And the question is, my impression was patients are asleep during these procedures. Seems like the patient is awake.
Patient's asleep. Do you move, Gail, when you dream? You're still asleep when you're dreaming and you move around, you make sounds sometimes. People grind their teeth when they're asleep, they fart. Some people pee their beds, but they're still asleep. So these are basic, primitive behaviors that are released during anesthesia. Sometimes, some people, not everybody does those things, but you're still asleep, but you still can move while you're asleep, right? Think about it. When you go to bed at night, you always wake up in the same position you went to sleep in. The answer is no. Sometimes I find myself on the other side of the bed, on top of my wife, and she's not happy about it. But point is, we move, we make utterances and guttural noises, and we do all kinds of bodily activities while we're asleep. So yes, he's asleep. Everybody is, and they actually don't remember the surgery. Now sometimes some people will, but we give them medicine not to remember anything in case they are awake for a little bit. All right, 30 seconds. Great question, Gail. We talk to the patient like they're awake because maybe they are. And we don't want to be impolite. So we'll have a conversation even though to you it may sound like the patient's awake and we're talking, but they're not actually awake. It's kind of like visiting somebody you care about who's in a coma. You still talk to them, just to give them that peace, make them feel better, right? You hold their hand. They may not even know you're there, but you still do it anyway. All right, we're done. Great question. If you have questions, feel free to type them up. I'm going to come and answer them for you all shortly. We're done with our second surgery. Like I said, the first surgery already went home. She's doing great. Her neck pain's gone, her headaches are gone, her arm pain is gone. 100%. Her strength is back to normal in her arms. This patient will probably take an hour recovery, and then we'll send him home as well. He's from out of state, so he'll go back to his hotel tonight, and then I'll see him in the morning. And when I see him, I'll examine him, make sure he's doing all right. And we'll send him on his way. The follow-up for this type of surgery is 1 day. If someone's having problems, they can always call me and we talk. We can even do visits virtually through Zoom. It's amazing what you can do on Zoom these days. All right. So we did 3 discs. One of them was done on both sides, called bilateral. That was L4-5. And surgery is over. It's gone very well. Had no problems. Did you close the other side yet? No? All right, so let's take a look. I need pressure here. Wake up. All right, surgeon's done. Write it down, please, the time on the board. Jordan. 2:47. 2:47. All right, folks, you see that? 7 millimeters.
Yeah, we see it.
Let's go ahead and show people what we just did, the Deuk laser disc repair. And then after that, show them a comparison to what a fusion would be like. And I'll come answer your questions, so type them up.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk Laser Disc Repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk Laser Disc Repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
And hello, I'm Dr. Ara Deuk-Machen. You've just been watching us perform spine surgery live with a live broadcast or stream over the internet on YouTube, Facebook, Twitter, LinkedIn, and we are taking your questions today during surgery. Now, we've finished 2 surgeries. We've got 1 more to go. And guess what, Joe? We've got 4 surgeries on Thursday too. That's going to be my new thing. Guess what, Joe? All right, so when you hear me say it, it's like saying Simon Says, or you know what I mean, Joe Green. Anybody know who Mean Joe Green was? He was a football player. And his name was Joe Green, and he had a reputation for being really mean. So they called him Mean Joe Green. And everyone in the 80s that grew up, we always used to say, you know what I mean, Joe Green? So it's one of those 80s things. So right now, I'll just say we've done the surgery. It's gone great. You know, we found a lot of herniation, and really that you know, you could see the annulus, and it was healing nicely, and it was just ripped, and there was more herniation, but really a lot of it was mostly just tear and some more jelly getting squeezed out. We call the nucleus pulposus the jelly. I use it interchangeably. But basically I was able to go in with the endoscope, find the tears, clean them out with the laser, remove the big pieces of herniation. I think this patient's going to do fantastic as long as the patient does what they're supposed to do, which is wear their back brace for 6 weeks, no bending at the waist, don't do any overstretching, just go for a walk every day, twice a day for 20 to 30 minutes, swing your arms for about 2 weeks, just get some exercise like that way, and you can go back to work and do stuff right afterwards. Usually people can go back to light duty work the next day if they want to, but everything went really well. And we showed you some videos during the surgery to show what it is I'm doing with the laser to repair the annular tear, debride it, and to also clean out the herniation. You know, we in medicine use terms like, oh, I did a fusion. Well, for those of you who understand what that means, fusion is when you take 2 bones and there's a gap between those bones, a space, and those bones move relative to each other, so they're not stuck together, and you fill that gap with bone graft, and over time what happens is those bones mend together and they become one solid bone, and that's a fusion. You're fusing 2 bones together, okay? So when a surgeon does a fusion, they're not really fusing the bones. We're putting the bone graft there, we're decorticating the surface, we're setting everything up so that fusion will occur, but the patient's body has to do the fusion. and it's not the surgeon doing the fusion, even though we call it fusion surgery or doing a fusion. Same thing with the Deuk laser disc repair. We're not repairing the disc, we're setting it up so the disc can repair itself. All right, the repair is done by the patient, and the way patients will heal their disc and repair them after I get in there and clean out the annular tear, remove the herniation stuck in there, their disc will heal as long as they do everything right. So good nutrition, vitamins, avoid re-injuring the disc while it's healing. Don't keep disrupting it by doing twisting and bending and lifting. Just take it easy, let it mend and heal. It literally takes, probably 6 to 9 months, maybe even a year in some people that heal slow. So 9 months on average to completely heal. If you get the Deuk laser disc repair and you take it easy for 9 months, it will heal and you won't have to come back. We have long-term data on patients that we followed for 6 years on average, at a minimum of 5 years, but an average of 6 years in this group, and they had 92% of their back pain was still gone after 6 years. And that's called long-term outcomes data. And you don't have that for most spine procedures. As a matter of fact, there's really almost zero long-term outcome data. Nobody has 6 years data. The number of spine studies published in the literature, in the medical literature that's peer-reviewed and published, that have greater than 5 years of follow-up is like one study. That's our study, basically. So the good news is the Deuk laser disc repair works and it lasts as long as you don't do anything you're not supposed to do to re-injure the disc. The re-injury rate is 1%, maybe it's 1.2%, but it's somewhere around 1%, just above it. That's 1 in 100 people will re-herniate. So don't be that 1 in 100. Follow your instructions. Take it easy. Let that disc heal. Any questions?
Yes. Our first one comes from Elaine Kiefer on Facebook. And they asked, how can I help you, Dr. Deuk, get the government to wake up and help you and me? I will do whatever it takes to have proper treatment that you perform.
Yeah. So Elaine, thanks. Elaine is listening and learning and understanding that, Elaine, how can you help? I mean, we need grassroots. That's really what it comes down to. How do you change the government? You need the people to rise up, and I don't want to go to jail for this, but rise up as in get involved, get educated, get knowledgeable, go and talk to the politicians, your representatives. Look at what's happening to the United States. When I was a kid, when I was my son's age, he's 17 years old, my daughter's 16. When I was their age, the United States of America was ranked #1 in the world in healthcare. #1. Now, I mean, #1 without question, without doubt. We were sending doctors all over the world to train other doctors. We had the best healthcare system in the world. Now we are like in the 30s. And it's not because, other countries have gotten better. Well, we've gotten worse. A lot worse. A lot worse. And it's shameful considering we spend the most amount of money on insurance, health insurance, than any other country in the world. The problem is the insurance companies are stealing our money, and they're not using it to take care of patients. They're keeping it as profit, okay? And the other thing that's happening is in medical record systems. It's called electronic medical records. This is the biggest scam in the last 15 years of healthcare. Electronic medical records. These are companies that create software, databases, where you plug in all the patients' medical numbers, their labs, their MRI, this, that. It's a database. And hospitals are paying $50 million, $100 million for each of these databases. The VA system, the veteran system of the United States, was going to pay Cerner $3.9 billion for an electronic medical record system. $3.9 billion. Guess what? It ballooned, which of course it ballooned because the the medical record company knew it would balloon. They give you hidden charges and fees, and by the time the VA is about to launch it, it's now $16 billion. So literally 400 times more. $16 billion the VA is spending so far on launching their new electronic medical record system. I'm going to tell you something. I worked at the VA for 7 years. I worked at the second largest VA hospital in the nation, in Gainesville, Florida. Okay? Second largest. And I can tell you, the VA had an electronic medical record system before everybody else already. It was called Meditech. And I'm going to tell you something. Meditech was amazing. It worked fine. There was nothing wrong with Meditech. The problem with the VA system is that the way it works with the government, they don't want to spend the money taking care of the vets. So what they do is they have policies at the VA system where if surgery hasn't started by 1 o'clock, they don't let the surgery happen. So when you look at the surgery schedule for the day, it's short. It's literally 8 a.m. until 1, whereas most hospitals, it's 7 a.m. until 10 p.m., okay? Getting all the surgeries done that need to be done. The VA system shorts it and makes the anesthesiologist and the surgeons only go to clinic for a short period of time to see as few patients as possible. I'm telling you this, I worked in the VA system, it's a scam. It's all set up that way. So spending $16 billion on a medical record system for those veterans, and it hasn't even launched yet, and that's all money that could have been used to pay for surgery, it could have been used to pay for medications, it could have been used to pay for everything these people need to get better. Instead, it was given to some backdoor agreement with politicians and disgusting, people who are stealing and robbing our healthcare system. It drives me crazy. What drives me the craziest is not just the waste, but it's the lying to the public. If you're going to steal from people, at least have the honor and dignity to tell them, I'm stealing from you. Look them in the eye and say, I'm taking your money. All right? I'm going to steal your money. And then let them react. Let them do what they're going to do. Give them a chance to do it honorably and honestly. But they lie to you. And they say, oh, a medical record system makes the quality of medical care better. People aren't going to have the wrong medications given. They're not going to have the wrong studies done. Bullshit. Those problems still exist even with EMRs. And they're even worse now. All that's happened now is we're seeing fewer patients and taking worse care of patients. So this is squandered. Now, by the way, the VA just announced that they are putting on hold the release of their electronic medical record system. You know why? Because not only has it gone from 3.9 billion, 4 billion to 16, now they think it's going to cost $55 billion to launch it by the time all the overage fees and everything have been factored in. These companies are stealing you blind. Your health insurance, Blue Cross Blue Shield, Cigna, United Healthcare, all the insurance companies are robbing you. State Farm, they're robbing you. The VA system is getting robbed by pirates that work within the system, by politicians that pass laws that make these things mandatory, so you have to buy EMRs. So yeah, we need a grassroots effort. I'm vocal about it. I'm trying to educate the public about it. I don't have a dog in this fight. I'm not a veteran. I don't get any benefits from the VA system. I just see the vets suffer, and I see them lied to, and I'm disgusted. I also see this thing happening in spine surgery where, companies that manufacture screws and rods and make $10,000 putting those things in each patient, they're making rich while you're getting screwed. And I don't think that's right, especially when there's better technology like endoscopic surgery now for the spine. So that's why we promote the technology, we promote awareness, we promote knowledge. I made it. I'm happy with my career. I don't need to work anymore. I do it because people need me. I do it because I love helping people and I want to get them out of pain. So what can you do? You can talk to your politicians. Start locally, start at the state level. State laws control insurance companies. State laws control insurance policy, every policy except for Medicare. Medicare is at a federal level. That's going to take a little more work to change because, when they divide you, they conquer you. The federal government, Medicare is divided. It's not divided, it's centralized, okay? But at the state level, we can start making changes at the insurance companies and in policies at the state level with things like Cigna, United Healthcare, Aetna, Blue Cross. So we need state laws that force these insurance companies to pay for good medical care. They should not be able to deny it. If we can get that state laws passed, it's going to make it harder for these insurance companies to deny good medical care at the federal level. All right? Next question.
This next question comes from Brian Johnson on YouTube once more, and he asked, he said, I had an L5 and S1 fusion in Philly by a Dr. Vaccaro, who I believe is very good.
Alex Vaccaro.
Yeah. But I know I've had pain in my back, and I believe the pain is coming from L3-L4. Can you help, even though I had a fusion?
So yes, we've been asked. Brian Johnson from YouTube.
Yeah.
Thank you for typing in your question. 100% we can help you. No doubt about it. Mr. Johnson has had a fusion in his lower back done by Dr. Alex Vaccaro, who I know very well. Dr. Vaccaro is generally a good surgeon, but of course he works with residents, and residents are in training. So that doesn't mean it's a bad thing, and I'm not criticizing at all the surgery. So you are probably correct. You know your body better than anyone, and I'm glad you're aware of adjacent segment disease. I'm glad you're aware of where L3-4 is. And so the answer to your question is, it doesn't matter whether you're right, it's L3-4, or whether it's L4-5, or whether there's a problem with the fusion. We can help you. Back pain has a cause. The key is to understand the source. And when you look at a back, okay, forget about the screws and rods, just pretend they're not there. When you look at someone's lumbar spine,
We can say it, yeah.
yeah, you realize, you know, when someone says my back's hurting, the back is right here, okay? This is the back, this is the back. So what's here that could cause pain? Well, you have bones, you could have a fracture, you could have a sacral fracture, insufficiency, you could have a vertebral body insufficiency fracture, all right, but those are easy to see on CAT scan or MRI. Most people don't have a fracture. Most people's pain comes from a disc. That's these cushions between the bones. That's 80% of chronic back pain is a herniated disc, or 2 or 3, okay? We just need to get an MRI, we need to do an exam, and if you're correct, that's the L3-4 right there. Your pain would be just above your fusion, it would be at the top of your incision, okay? Now, the other things that cause pain, besides these discs, are facet joints, and maybe you can see there's a facet joint there, facet joint there, facet joint there, there's one on the other side. So facet joints move when you move. Your body moves, your spine moves, your facet joints move. They get arthritis, and they can be very painful. The key, though, is that they're usually lateralized to left or right, or you can have it on both, but they're off the midline. They're over here on the side, okay? So that's easy for me to figure out based on the physical exam, diagnostic imaging. So you are correct. We can figure out everyone's cause of pain, their back pain and neck pain. It's just a matter of using the physical exam and the map of where these joints are, and basically figuring out where their pain's coming from. Give me 1 second. When did they go out?
Oh, it was like 10 minutes ago? Give or take.
All right. So, hold on a second. What time is it now?
It is currently 3:15 on the dot.
3:15?
On the dot, yeah.
All right. So, sorry about that. I'm just looking at the operating room and need to communicate. But long story short, I apologize for the digression. The back pain, the neck pain, the thoracic pain, we can figure out where your pain's coming from. It's easy. That's the easy part. Fixing it is also easy. The problem is some people have more than one cause of pain. They may have 2 joints. They may have a disc and 2 facets, or a disc or 2 discs and 2 facets on the other side, but I can figure it out. The way we do that is physical exam, MRI, sometimes an EMG nerve test, and sometimes what's called diagnostic blocks, where we numb up a joint, see if it takes the pain away. But that's something we do at Deuk Spine all the time. You're not going to find these services everywhere. You have to go to a specialty center. You're not going to find the Eiffel Tower everywhere. You've got to go to Paris, France to see it. Okay? You're not going to find Mickey Mouse everywhere. You got to go to Disney World or Disneyland. So yes, sometimes in life, if you want the certain experience that you have to get, you got to travel for it. Now the good news is we can do almost everything virtually, and we do a free MRI review at Deuk Spine. It's mri.deukspine.com. Henry's going to type that address in right now and send it out to you guys, and Facebook and YouTube, right?
Yep.
And but if you know somebody in pain, you want our opinion, we do it for free. It's the year 2022. Maybe next year we're going to get too busy. I can't do it for free anymore. I got to charge people, but we try to do as much free things for people as we can. We want to reach as many people that are suffering out there as possible. My goal as a CEO and founder, and it's my money I'm spending, I want to spend some of my money to help people, all right? And that's what we do. That's what we do at Deuk Spine Institute. We try to help people as much as possible. So, look forward to reviewing your MRI with you.
Next question comes from Gail Clark on Facebook.
Gail Clark, hi.
And they asked, are there some conditions which the Deuk endoscopic laser procedure cannot help?
Hi Gail, are there some conditions which the Deuk laser disc repair cannot help? All right Gail, nice to see you. You're seeing me, I believe, hopefully. I haven't seen your face, but I do correspond in some of the Facebook groups with you. And I'm glad you're here to watch live surgery. So Gail and everyone else that's interested in this, I'm going to show you once again the spine. The spine is made up of bones, which is this yellow thing, and discs, which is the white thing, and bones. So it goes bone, disc, bone, disc, bone. And the discs are really joints, they're cushions, they move. And then in the back part of the spine you have, again, bone, facet joint, bone, facet joint, bone, facet joint. So you got joints in the back of the spine and joints in the front. Take a patient with chronic back or neck pain. 80% of that pain, 80% of the time, it's coming from a herniated disc. That's what the Deuk laser disc repair does. It fixes disc pain, pain from a damaged disc. I say herniated, it could be degenerated, herniated, extruded disc, protruded disc, bulging disc, migrated disc, you name it, any problem with the disc that causes pain, the Deuk laser disc repair fixes that. So, Deuk laser disc repair fixes 80% of chronic back and neck pain with that surgery. 15% of patients have pain coming from this facet joint, okay? Either the right or the left facet joints, and it could be 2 or 3 or 4. The Deuk laser disc repair doesn't work for that. We do something called a rhizotomy. You've probably heard of it before, radio frequency ablation. Radio frequency ablation. We take a little probe about as big as this staple, and we go right down here, and we put it where the nerve is that transmits pain from that joint, and we burn it. That's what's done. It's done all over the world. It's called the MBB RFA, medial branch block radio frequency ablation. Now, what Deuk Spine has done is I've pioneered a new way of deadening these nerves back here with plasma, and it's called the Deuk plasma rhizotomy. And it's for patients who have tried the RFA, and the RFA is given relief, but the nerve grows back quickly and the pain comes back. With the Deuk plasma rhizotomy, when we deaden that nerve to the facet joint, it's called the medial branch of the dorsal ramus. When we deaden that with the plasma, it doesn't come back, or at least it hasn't yet in any of the patients we've treated. So at the Deuk Spine Institute, we fix 80% of back pain by treating the disc with the Deuk laser disc repair. We fix 15% of back pain by treating the facets with the Deuk plasma rhizotomy. So that's 95% of back pain. Where's the rest of it come from? Well, some people have pain coming from their SI joint right here. It's called sacroiliac joint dysfunction or SI joint disease. That requires shots, and sometimes it requires a fusion. Then some people get pain in a muscle in their back here called the piriformis muscle. And again, that's treated with shots and stretching. So the Deuk laser disc repair can pretty much fix all disc problems And the Deuk plasma rhizotomy can fix all facet joint problems that cause pain. And that represents about 95% of chronic back pain.
And then, last but not least, we have a question from Shane B on YouTube.
Hello, Shane B.
And they said, I'm going for a cervical epidural. Do they work? What's the risk? Nobody can seem to give me an exact answer on what my problems are. I've had nerve release surgery and they did not fix my issue. I've had 2 different doctors saying I do need an ACDF and one saying I don't.
Hey Shane, thanks for tuning in to the live broadcast of spine surgery at Deuk Spine. And yeah, you are dealing with a problem that so many people deal with, and that is not knowing what the right answer is, not knowing the truth, okay? What we want to do is give you the truth at Deuk Spine. We will give you the truth. But you're asking me to answer a question that I can't possibly answer just based on the information you've given us in your post. I need to see your MRI. I need to actually do a video conference where I can look at you and see exactly where your pain is coming from and where it's going. If I could do that, I'll tell you why you have pain and I'll tell you exactly what needs to be done to fix it, all right? Now, let's say for a moment the pain is coming from the disc, all right? The nerve release you had, if I'm not mistaken, may have been done through the back of your neck. Those don't work. That's why we always go through the front when it comes to the cervical spine, because that's the best way to fix things is the front. Going through the back is half-assed. It never really works. So what I'm saying to you is I can answer your question, what's causing your pain. I can tell you what needs to be done to fix it if I do a free MRI review for you virtually, okay? Now, let's pretend it is the disc herniations. Do you need to do an ACDF? The answer is no. Now, if your surgeon only knows how to do an ACDF, that's all they do, okay? They only know how to take the discs out and put in cages and put a metal plate. If that's all they know how to do, because that's all they were trained to do, then that's all they're going to offer you. They will never offer you endoscopic surgery like what we do today, where we go in with a little cut and we fix the disc, and there's no fusion, no metal. Because I can do ACDFs, because I can do artificial discs, because I can do foraminotomies and laminectomies, I can do it all, and I can do endoscopic. I always choose the best for my patient, and I recommend the best for the patient. That would always be endoscopic laser as long as the disc is the cause of your problems, which I believe it is. But I need to confirm that by reviewing your MRI and doing a free MRI review. Okay? Now, will the epidural work? So what happens in an epidural is the doctor who developed the epidural realized that a lot of people's pain in their neck comes from the herniated disc, but that doctor couldn't fix the herniated disc because they're not a surgeon. They're an interventional pain management doctor. The best they can do is stick a needle in your spine, inject some medicine close by to the disc, and hope it gets over there and reduces the inflammation. That's what an epidural is. It reduces inflammation in the spine that's coming from a herniated disc. Really, it's going to wear off even if it works. Is it safe? If I did it, it would be safe. If Dr. Patel did it, it would be safe. But there's a lot of hacks out there I wouldn't trust. And they're sticking a needle right where your spinal cord is. So God forbid they screw up, and I've seen them screw up. You could be paralyzed. Just go to our YouTube channel, check out their video on the patient who was paralyzed from an epidural in the cervical spine. We didn't do it. It was done down the street. I won't tell you who did it. Well, I will. It was Florida Pain, okay? They did it, and they got offices all over. They don't care about people. They just want the money, so they got a bunch of hacks sticking needles in people who aren't really qualified to do so. But, you know, if it was me, I want the best. If it was my kids, I want the best. I don't want my kid paralyzed because some doctor was careless, all right? There's a lot of bad doctors out there. And, you know, the truth is, there's shortages probably of doctors, and it's hard to get and find a good doctor. So a lot of people just settle and go get something done where they live. Don't do that. Travel, go to the best, go somewhere you trust, get great care, and then you'll never regret it, okay? That patient who was paralyzed, she's made a partial recovery. She is suing those people. and I think she's going to win. All right, but it never brings back her normal strength in her arm. She's always going to be partially paralyzed. So they screwed her over. So is an epidural safe? Usually it is, as long as it's done by somebody who's really good at doing it and has the right equipment, the right training, and actually cares to make sure you don't have a complication. I've seen horrible complications from epidural. I've seen infections of the spine. I've seen spinal cord injury. I've seen nerve damage. And to be honest with you, all these epidurals they do, they don't last. My opinion, don't do it. I don't recommend epidurals. You know, I don't recommend them anymore. I used to recommend them for years. I used to recommend them as an initial treatment. But now that I know what I know about epidurals, they don't last, they have complications, and people are going to keep getting them over and over again. I don't think it's an appropriate treatment. You want definitive fix, you go get the definitive treatment. And that's something we can help you with.
We have two more questions. The next one comes from Brian Johnson once more.
Brian?
And he asks, how backed up is your schedule? I have already sent you my MRI and have a virtual appointment on the 19th.
Hey Brian, thanks for commenting. Yeah, I'll just be honest with you. You know, we've had a lot of turnover of staff. So is a lot of people. A lot of businesses are hurting right now trying to get workers. I've got some really good people, but we've had some turnover, and that's resulted in delays in the MRI reviews, because obviously I don't do most of the prep of getting the MRIs, writing the emails, scheduling. I've got people to do that. We've got a new gal doing it now. Her name is Darcy, and my opinion, I think she's going to do the best job. The last person that was there, not so good, didn't take very good notes, walked off the job one day, didn't even show up. He actually walked off the job when we had 20 MRI reviews scheduled for that day. He literally just walked off the job and didn't even bother calling the patients. So that kind of shows you the kind of people, unfortunately, that we have to deal with. Not my kind of people, but at the same time, when you're interviewing these people for the job, they don't exactly say to you, I'll be walking off the job 3 months from now. Because if they did, I wouldn't hire them, obviously. That said, we're trying to get that program going again. I've got Darcy. She's really, really smart, really good. And yeah, I'm sorry. As far as my schedule goes, it can get busy. So, but usually we can get people in that really want to get in. We can get them in within 2 weeks. 2 weeks. But remember, these are surgeries. So everybody that has this surgery needs what's called preoperative clearance. Preoperative clearance means that we've got to check your heart and lungs and make sure you're fit for surgery. Okay, give me 1 second. So what's a medical clearance? You need an EKG, you need blood work, and you need a primary care doc to check over the EKG and blood work, do an exam, listen to your heart, your lungs, make sure there's no kind of bruit or weird sounds, something's broken. And as long as you're healthy and fit, then you got to be off your anti-inflammatories for 10 days, like your ibuprofen and Motrin, Naproxen, BC powder, Goody powder. Got to be off ginkgo biloba, fish oil, turmeric, any of those herbals. As long as you're off that stuff for about 10 days, you can get your surgery done. And we do clearances here, by the way. So if you can't get to a primary care doc, come to Deuk Spine. We'll do the clearance here. We've got doctors to do it. We've got our own EKG machine, our own labs, our own x-rays. We got everything. We're self-contained. This way we don't have to rely on incompetent systems that are outside of our facility that just waste time, and they waste people's money and patience.
All right, and then last but not least, we have Jacob on YouTube.
Hi, Jacob.
And he said, I have ankylosing spondylitis. I'm having trouble with herniated disc. With a herniated disc. What is best for me to do?
Hi, Jacob with ankylosing spondylitis. Sorry to hear about that. Really am. But so ankylosing spondylitis is a condition where the discs fuse themselves with inflammation. If you're having trouble with the disc, I would love to look at it. I'd be happy to check it out and give you my opinion. If it's something I can fix with the laser surgery and get rid of your pain, absolutely happy to do it. Now here's something that ankylosing spondylitis patients get. Their spine fuses solid. and then they're walking along someday, they fall and, you know, they twist and they crack their spine. They get a fracture. Now, if that's what you have is a fracture, you have to have a fusion to fix it. My laser surgery will not work. So if you have an ankylosed spine and you fell and you fractured it, you must have a fusion. My laser surgery will not work. I can do your fusion for you if you want, no problem, but you will need a fusion. On the other hand, if that's not your history, if you just have a painful disc herniation, I can definitely fix it for you with the laser. I just need to know what side and what level. All right, send us your MRI. Be happy to do a free MRI review. I've enjoyed our time together. Great questions from the audience. I hope you keep watching. Our next patient, she has a herniated disc at L5-S1, that's the bottom of the spine, and L4-5. So we're going to be doing L4-5, and bilateral means both sides L5-S1 because both nerves are pinched on both sides. We'll be back in about